Okay, so we'll talk about when to use systemic treatment, what are the standard treatments that we use in the United States and how that fits in with dupilumab, and then some new treatments. So I didn't want to talk about systemic treatment until I just told you how we treat moderate to severe atopic dermatitis without systemics. And just like European guidelines, we use topical steroids to clear the disease. That's that yellow box. Daily for 2 to 4 weeks. And then intermittent topical steroids or calcineurin inhibitors for long term. Okay, and so if that fails, if that doesn't keep the patient improved or they can't reduce their topical steroid use, that identifies a patient as needing systemic treatment. We do a lot of proactive treatment, so I don't know if you use that term in Spanish, proactive, but it's basically treating normal skin once it clears with topical steroid. So intermittent topical steroid to normal skin or calcineurin inhibitors to normal skin. And that can be aggressive treatment that can reduce your flares. And I'm not going to go into this graph too much. This is just looking at proactive treatment versus emollient. And you can see that in this vehicle group, the patients flare in 31 days versus in the 3 times a week calcineurin inhibitors, patients flare after over 100 days. So it can reduce relapses. Okay, so when someone fails topical therapy, what does that look like? How do you make a decision to move to systemics? So everyone used to ask me, well, how do you define moderate to severe dermatitis, Dr. Simpson? How do you do that? And I got tired of that question because I don't think about that as much in clinic when I'm seeing patients. I think about you're a topical treatment patient, or you're a systemic patient. I don't worry about moderate to severe. And so we got this group together, the International Eczema Council, and we asked all the experts how they define who should get a systemic. And so it's if aggressive treatment is not working, the topical therapy that we talked about. You've really talked about steroid phobia, education. You've made sure there's not a chronic infection. There's a large impact on the quality of life. And then before you go to systemic treatment, it's an important time to think, is there something else going on? Is this really CTCL? Is this really allergic contact dermatitis? What's happening? So stop and think about that. Consider phototherapy. In the United States, it's kind of expensive. It's kind of inconvenient. So often patients, it's difficult for them to do. But once you've checked off these boxes and you discuss it with the patient, give the options, that's a patient who needs systemic treatment. Treat the patient. They're suffering. As you know, you see these patients. And just a couple of things that I do in clinic to help me make this assessment, to help me follow patients. I do a modified EASI score. So I look at the erythema, the body surface area. We use patient-reported outcomes. So we ask about itch, intensity. We ask about quality of life. You can use different instruments. I have a patient give their global assessment, mild, moderate, or severe, and I do my personal assessment. They don't always match. And I measure the body surface area generally and a global signs intensity, so erythema, papulation, lichenification, and excoriation. That's just what I do in clinic. Okay, so that's when to use systemic. What about the traditional systemic therapies? When you read guidelines, they don't tell you how to use them. There's like 4 to 6 different ones, but they don't say which one you start first, which one do you go second. So I'll just tell you my interpretation of the guidelines and how I do things in clinic. This is similar to many people many dermatologists in the United States. So I love cyclosporin. I probably give cyclosporin to too many patients. This was my traditional algorithm as of a year ago. So a year ago, dupilumab was approved. So it changes a little bit, but let's talk about traditional ones.